So folks, in this video we will recapitulate what we have studied in drugs for angina pectoris. So we have seen that nitrates are the most effective drugs for the treatment of angina. Why so? Because they are responsible for both decreasing the preload as well as increasing the oxygen supply. That is, they tend to cause preferential venodilation, so there is a decrease in the oxygen demand as well as increase in the oxygen supply due to coronary vasodilation. Further, all nitrates are found to undergo extensive first-pass metabolism except isosorbide mononitrate, which is the only nitrate that does not undergo any first-pass metabolism. Next, all nitrates are long-acting except nitroglycerin. Nitroglycerin is therefore the shortest acting nitrate. Then which is the longest acting nitrate? It is pentaerythritol tetranitrate. Next, what are the indications of nitrates? They are effective in angina pectoris, congestive heart failure and hypertension. In both angina pectoris and congestive heart failure, they reduce the preload and hence they reduce the workload on the heart. In hypertension, they reduce blood pressure by causing venodilation. Further, relaxation of the smooth muscles also occurs in the GIT, so they are effective in relieving esophageal spasm and biliary colic. Further, nitrates, by causing or rather increasing the formation of methemoglobin, they can chelate the cyanide and therefore they are used in the treatment of cyanide poisoning in combination with sodium thiosulfate. The administration of nitrates combines with hemoglobin to form methemoglobin. Methemoglobin combines with cyanide to form cyan-methemoglobin, and this when added to sodium thiosulfate forms sodium thiocyanate, which can be eliminated. Then the adverse effects of nitrates: because of vasodilation, they can cause throbbing headache and flushing, hypotension and reflex tachycardia. Further, methemoglobinemia is an adverse effect because they combine with hemoglobin and they form methemoglobin. Also, long-term use of nitrates is associated with tolerance. Then we discuss the fatty acid oxidation inhibitors or PFOX inhibitors. One is ranolazine, which is the first-line drug for the treatment of chronic angina pectoris. Why it is considered to be the first-line drug? Because it is claimed to be cardioprotective, plus it is found to improve the glycemic control. The other drug in this category previous to ranolazine was trimetazidine. Trimetazidine is found to reduce the frequency of anginal attacks as well as increase the exercise capacity. However, this is not a first-line drug. It is mainly used as an add-on drug for the treatment of angina pectoris as well as post-MI cases. Then we discuss the potassium channel openers. These are never used as the first-line drug for either angina or hypertension. Why? Because they are associated with salt and water retention, which tends to increase further the blood volume, and therefore it offsets whatever benefit was obtained in angina and hypertension. Further, due to blockade of insulin secretion from the pancreas, they are associated with hyperglycemia. In addition to angina and hypertension, minoxidil is effective in the treatment of alopecia. It is supposedly found to increase the blood supply to the hair follicles. Diazoxide, by reducing the insulin secretion in the pancreatic beta cells, it is useful in the treatment of insulinoma, which is a malignant tumor associated with excessive insulin secretion. Then we discuss Evaporating, which is a funny current inhibitor. It tends to inhibit funny current in the SA node. It is approved for the treatment of chronic stable angina pectoris in those patients who have a normal sinus rhythm and who are intolerant to beta blockers. Because it tends to reduce the heart rate, side effect is bradycardia. So therefore, Evaporating is generally preferred only in those patients who have a heart rate at least of 72 beats per minute. Thank you very much.